Okay, so I'm going to discuss anti-CD20 monoclonal antibodies in the treatment of glomerulonephritis. Okay, so the use of monoclonal antibodies have transformed the lives of millions of patients. So CD20 is universally expressed on B cells in all stages of development, and the use of rituximab is very widespread. Ofatumumab is a humanized anti-CD20, which is no longer available, and now there's the emergence of obinutuzumab in autoimmune kidney disease. And there's also the possibility of using anti-CD19 CAR T cells in the near-ish future. So here you can see that CD20 is expressed on the immature B cell all the way through to the memory B cell. And as the plasmablast develops, the plasma cell loses CD20, and instead there's the emergence of the plasma cell markers such as CD38 and BCMA, so B cell maturation antigen, which are the targets in myeloma treatment. So this picture shows how the molecule of CD20 has these four membrane spanning domains, and it's the extracellular part of the loops, which are the main target for these monoclonal antibodies, with rituximab binding to the large loop of the distal epitope. So rituximab, as I said, is a chimeric monoclonal antibody specific for CD20. So it will target and destroy both normal and malignant B cells. It was initially approved in 1997 by the FDA for treatment of low-grade or follicular non-Hodgkin's lymphoma. The first publication of the use of rituximab in autoimmune disease was in 2001, colleagues at UCLH, which used it in the successful treatment of patients with rheumatoid arthritis. And the use of rituximab really centers on the important role that B cells have in autoimmune disease. So B cells give rise to plasma cells secreting autoantibody, as well as the ability of these autoantigen-specific B cells to present antigen to autoreactive T cells, which result in T cell activation, cytokine release, and inflammation. So rituximab is able to kill B cells by three different pathways. So first of all, as shown here in this diagram, there's the binding of rituximab, which results in the activation of the complement cascade. There's a generation of the membrane attack complex and direct lysis by complement-mediated cytotoxicity. Additionally, the FC portion of rituximab binds to deposited C3b fragment. This results in the recognition by FC receptors plus complement receptors on macrophages, which causes phagocytosis and antibody-dependent cell-mediated cytotoxicity. And the third pathway to mention is the binding of rituximab allows interaction with NK cells. This is via the Fc gamma R3 and complement receptor 3, which results in antibody-dependent cell-mediated cytotoxicity. So the first open label study of rituximab in active lupus involved 6 patients. It was now published over 20 years ago. So these patients were treated with 0.5 gram of rituximab plus cyclophosphamide with steroids, which resulted in improvement in lupus markers, protein creatinine ratio, and the BILAG scores all improved. So the next landmark paper to mention was combining all the data from European cohorts, which included 164 patients with lupus nephritis with refractory or relapsing disease, and 2/3 of patients had a response to rituximab. And this really based the foundation for going on to a randomized controlled trial, which unfortunately were disappointing. So I'm not really going to mention the Explorer trial, which is non-renal SLE, but the LUNAR trial involved patients with lupus nephritis and was published now in 2012. So all patients had biopsy proving class 3, 4, or 5 with proteinuria. And those patients with more sclerosis or a lower GFR were excluded. All were treated with prednisolone. I think the important point here was very high doses of MMF, the maximum 3 grams a day, and it compared rituximab versus placebo. The primary endpoint out to a year looks at a complete renal response. So this is very, very strict criteria. Normal creatinine, inactive urine, no proteinuria, so very tight. And also partial renal response, which did allow a bit more proteinuria. So 144 patients were recruited, and ultimately this trial did not demonstrate a difference between the rituximab and the placebo group. Therefore, superiority was not achieved. There were similar adverse effects in both groups. Few caveats to add that actually there was a greater partial response in the patients given rituximab, and also patients of Black ethnicity, which is a higher risk group, also seemed to respond better to the rituximab arm. However, this trial was underpowered to detect a difference in partial response rates. It's also important to note that 8 patients needed rescue therapy with IV cyclo in the placebo arm, whereas none in the rituximab arm needed cyclo. And there was a trend for patients of African ethnicity to respond favourably to rituximab, which I think is a really important point in this trial. And it's likely that the large doses of steroids and the large doses of MMF completely overwhelmed the effect that rituximab could potentially have, and superiority would have been very difficult to achieve in this trial design, and the criteria for complete response are very strict. However, since then it has been demonstrated that meta-analysis does show significant differences in the complete renal response in those patients treated with rituximab, with lower BILAG and SLEDAI scores, lower doses of prednisolone are achieved, and there's strong evidence now to use rituximab in patients who fail conventional treatment. So it's widely used in lupus nephritis. It can help minimize the steroids. But the side effect is that many of our lupus patients unfortunately do generate these human anti-chimeric antibodies and have allergic reactions, which limits its use. I just wanted to demonstrate here, this is taken from the KDIGO guidelines, and it's slightly disappointing to me that rituximab is not mentioned here, but despite this, I think rituximab is very widely used in the UK. Okay, so how about rituximab and vasculitis? It's just to compare this with the lupus trials, as there's been great success with really well-designed trials showing how effective rituximab is in patients with vasculitis, and has transformed this disease from having a fatal outcome before the onset of immunosuppression to now being this relapsing remitting disease that we often see in the clinic. And the success of B-cell depletion therapy really focuses on the central role of B-cells in the pathogenesis of ANCA-associated vasculitis, due to the production of ANCA-producing plasma cells, B cells functioning as antigen-presenting cells to support T cell activation, and the production of specific B cell cytokines, especially BAFF and BLyS. And BAFF levels have been shown to correlate with ANCA disease activity. So unlike the lupus guidelines, we can see rituximab is mentioned throughout the treatment of vasculitis. It's used in the treatment of induction, the treatment of remission, and it's used in refractory disease. And we know it's better to use it in patients with relapsing disease compared to cyclophosphamide. So Professor Salama has already been through the vasculitis trials, but to summarise just very briefly, it's used in induction of remission. It's based on 2 landmark trials from 2010. The first trial, rituximab, compared rituximab versus cyclo for induction of remission. And the important point about this trial is it included patients with severe renal disease and compared prednisolone plus either rituximab alone versus IV cyclo, then switched and stepped down to azathioprine. The median GFR entry of this trial was only 18 mils per minute, so severe kidney disease. And it's basically this trial showed no difference in outcome in the 2 arms, with both treatment arms having sustained remission. Importantly, the median GFR increased from month 0 to month 12 by a similar amount in both the arms, with similar adverse effects. The second trial to mention was a slightly different trial. It included patients not just with renal disease, with extrarenal vasculitis as well, was a non-inferiority trial, or patients treated with steroids, and the endpoint of this trial was a BVAS, so vasculitis activity of 0, and be completely off steroids by month 5. So this trial compared rituximab and steroids versus daily oral cyclo with a switch to azathioprine. So it's basically showed similar numbers of patients in both arms reaching the endpoint. When they looked at patients with severe kidney disease, again, it was very similar, with a similar increase in GFR at 6 months and similar numbers of patients reaching their endpoint. So that provided plenty of evidence for rituximab in induction of remission. So how about maintenance? So again, 2 landmark trials. The first trial to mention, rituximab, which I'll go through quickly. This has already been discussed. So this trial compared rituximab with azathioprine. So this trial, all patients were given rituximab and steroids as induction therapy, followed by either further rituximab or azathioprine. Steroids was withdrawn at month 20 and the follow-up was out to month 36. So this trial basically demonstrated there are many more relapses in the patients who had azathioprine as maintenance compared to rituximab. Therefore, rituximab was superior in preventing relapses with a hazard ratio of 0.41, and there were no differences in rates of hypogamma, which is always a concern with repeated rituximab dosing. There were similar adverse effects in both groups. The second maintenance and the last trial to mention in vasculitis are the main RITSAN, which looks at a European cohort. This is different to the previous trial in that all patients had induction with IV cyclone steroids, not a rituximab-based induction regime. Unlike the previous study, this is also predominantly newly diagnosed patients rather than relapsing patients. So following induction therapy, all patients were treated with rituximab and redosed with rituximab at month 6, 12, and 18, and this was compared to daily oral azathioprine. The endpoint was out to month 28, and which was defined by BVAS of 0. There are many more patients with GPA and PR3 ANCA, which you would expect to relapse more. And this trial basically demonstrated again that rituximab was superior to azathioprine in the maintenance of remission and preventing relapses. So in the azathioprine group, nearly a third of patients relapsed with long-term follow-up compared to just 5% in the rituximab group with similar adverse effects. So I think this really helped provide evidence for the use of rituximab in induction and maintenance of vasculitis. So how about rituximab in membranous? Actually, I'll go through this pretty quickly because we've already discussed this, but basically it works. However, there's an issue with high levels of antiphospholipase A2 receptor antibody. We know these patients are more likely to have a severe nephrotic syndrome. They're less likely to remit. There's a risk of declining function and lower response rates with rituximab. So we know in membranous, repeated doses of rituximab may be required. Long-lived plasma cells hang around. They're likely to cause resistance to rituximab, and there's definite concern about the efficacy of B-cell depletion therapy in those patients with very high levels of antibody. As we know, rituximab may be less effective with high levels, and this was shown actually in an early study published a number of years ago. This demonstrated with very high levels of antibody, cyclophosphamide was still very efficient at depleting the antibody. However, with rituximab, the higher the level of the antibody, the less likely you were for the antibody to decrease with rituximab treatment, as shown in the left of this graph. So how about the use of rituximab in patients with nephrotic syndrome? And I think the discovery of autoantibodies against nephrin has been the big news in the world of nephrotic syndrome over the past few years. And this study to mention looked at 62 patients with minimal change disease, 41 children, 21 adults, and they basically demonstrated up to a third of patients had the existence of anti-nephrin antibodies. There was a complete or significant decrease in the level of antibody when these patients responded to treatment. This paper also showed high levels of antibody pre-transplant in the patient with FSGS who went on to have prompt transplant recurrence. This study concluded slightly an underestimate of the prevalence of autoantibody in patients with membranous, as nearly all these patients had initiated treatment, and nephrin antibody may also have a role in a proportion of patients with primary non-genetic FSGS. So rituximab is widely used in the treatment of patients with steroid-sensitive nephrotic syndrome or minimal change. It has numerous effects. So rituximab is able to bind to this protein I've mentioned to stabilize the cytoskeleton, therefore it has direct antiproteinuric effects. Rituximab obviously is B-cell depletion and a reduction in autoantibodies, and that's a highly desirable effect in patients with nephrotic syndrome, especially with the discovery of anti-nephrin antibodies. And rituximab will also result in the depletion of antigen-presenting B cells, restoring the balance between Tregs and autoreactive T cells. So a meta-analysis published in 2020 looked at 16 studies of over 200 patients with FSGS and minimal change and followed up these patients for a median of just over 2 years. And they basically demonstrated with rituximab, with minimal change, had a very high remission rate. So 80% of patients responded to rituximab, decreasing to just over 50% of patients with FSGS. About a third of patients had a relapse following rituximab compared to 50% of patients with FSGS with long-term follow-up. And about 3/4 of patients with minimal change have a long-lasting remission with rituximab compared to 43% of patients with FSGS. A few caveats with this meta-analysis: there's a variety of steroid dosing, a variety of rituximab dosing, and it's unknown the exact duration of remission. So this is a publication just from last month in JASN, which we contributed a few of our patients to. This is a long-term study involving many European countries, involving patients with minimal change or FSGS who had at least one dose of rituximab. So 183 patients, most of whom had at least 2 or more immunosuppressive treatments, many of whom were steroid-dependent, frequently relapsing patients rather than non-responders. What this long-term study basically showed that a significant proportion of patients were in a complete remission and responded to rituximab. Those patients who were frequently relapsing steroid-dependent, 93% of patients responded. There was no response in just under half of the steroid-resistant patients, perhaps unsurprisingly, and we know that more patients with minimal change in FSGS seem to respond to rituximab. So this has followed up patients for 3 years, and at 3 years after rituximab treatment, about half the patients with minimal change have relapsed, about half are in complete remission. With FSGS, rates are lower, so about just under a third of patients have responded. However, non-response is in about 19% and relapses in 22%. What we do know with regular maintenance therapy, unsurprisingly, less relapses, and those patients who are treated regularly with rituximab have a significantly lower rate of relapse. And also what's interesting, there is still a subset of patients with steroid-resistant FSGS who may still benefit from rituximab treatment. So why is it some patients are still resistant to rituximab? So it's likely to be due to the formation of these human anti-chimeric antibodies, which are associated with incomplete B-cell depletion. We know there's persistence of B-cells in the kidney biopsy after the use of rituximab, and there's a limited ability of rituximab to penetrate tissues. There's also internalization of rituximab, which is a feature of this type 1 monoclonal, which compromises its ability to deplete B cells. Therefore, it's less efficient at evoking antibody-dependent cellular cytotoxicity. So binutinimab is a highly potent type 2 monoclonal antibody against CD20. And as we saw from the first few slides, it recognizes a different epitope on the CD20 molecule. It has a glycosylated Fc portion, which allows higher binding to Fc gamma receptors and more efficient killing. It internalizes less rapidly than rituximab, and the overall result is, although there's less complement-dependent cytotoxicity, there's greater antibody-dependent cellular cytotoxicity and phagocytosis and more direct cell death, resulting in superior B-cell depletion. So we've already seen some of the slides from the Nobility trial earlier on in the lupus session, but essentially binutinimab was investigated in the Nobility trial, so all patients had biopsy-proven lupus nephritis. All were given mycophenolate and a protocolized prednisolone wean. And the endpoint was minimal proteinuria and normal kidney function. So 126 patients were enrolled, half had placebo, half had binutinimab in addition to steroids and mycophenolate. And what this trial essentially showed, those patients treated with binutinimab had significantly greater overall renal response compared to those patients given placebo. And I think the data is really convincing. So we can see the patients in the binutinimab arm, significantly more patients respond, have increase in C3, increased C4, lower levels of double-stranded DNA, better preserved kidney function, lower proteinuria. And when you look at the B-cell depletion data and compare Nobility versus the LUNAR study, we can see that binutinimab results in much more profound and more prolonged B-cell depletion and therefore a better response. And the results of the phase 3 trial investigating binutinimab and lupus have not yet been published, but there has been a press release to say it's been a positive trial. So await that paper with great interest. So I've already mentioned this actually just before the tea break about the use of binutinimab in membranous. So I'll miss that. There's been some case reports looking at binutinimab in patients with ANCA-vasculitis. In those patients who've had allergic reactions to rituximab, unsurprisingly, it works, it's tolerated, and it's effective. And it's currently the study of OBVAS, which is a phase 2 study comparing rituximab versus binutinimab in patients with ANCA-vasculitis. There's been case reports looking at binutinimab in patients with minimal change and FSGS. And unsurprisingly, binutinimab works well in patients who have frequently relapsing disease. Just to mention CAR-T, CAR-T is basically an extremely expensive, very fancy way of B-cell depletion. And CAR-T allows deep depletion of B-cells, including at sites of inflammation. and it's shown to restore immune tolerance with re-emergence of a naive B cell with a new repertoire, so less autoreactive B cells. It's widely used in leukemia and lymphoma, and there's been great interest in using it in lupus nephritis and autoimmune disease. So the protocol for CAR-Ts is patients undergo leukapheresis, there's cell enrichment, the T cells are activated, and the CAR is delivered to the T cells using a lentivirus to target CD19, followed by expansion of T cells by IL-2. The patients undergo lymphodepletion with cyclophosphamide and fludarabine. The T cells are infused, and it results in deep depletion of CD19. So this has been the subject of a trial. I'll just finish this quickly. A trial looking at CAR-Cs in lupus, which was published in Nature Medicine just a few years ago. So the protocol, as previously described, this was a group of 5 patients, all young adult, all had kidney involvement and all had previous significant immunosuppression. All patients received the lymphodepleting chemotherapy followed by CAR-T treatments. And what this basically showed that there were significant improvements in their SLEDAI scores, and things like fibrosis of the cardiac valves has completely disappeared and all immunosuppression was stopped. I think the most striking results are on this slide. We can see following CAR-T treatment, within 3 months, the proteinuria goes from very high significant levels, completely comes crashing down to non-existent levels. Complement normalizes, DNA normalizes, and fatigue, which is a very troublesome symptom, also seems to disappear in these patients. B cells came back after about 110 days, and so far with long-term follow-up, just 1 patient needed steroids for a minimal change-like lesion. No patients had significant cytokine release syndrome, and there were no neurotoxicity features, which is always a concern with CAR-T treatment. So this does show promise in patients with severe refractory disease. However, there are issues with this, such as needing to stop antiproliferative treatment prior to the onset of leukapheresis. And of course, there are enormous cost implications, so I fully kind of appreciate that this won't be a treatment in many parts of the world. So just to mention that a CAR-T trial has just started at UCLH. This is my patient, Katie, who was in the newspapers recently, The Guardian and The Times, just the other week, having now had her CAR-T treatment back home. So we'll see how she does. So in conclusion, rituximab has many uses in glomerulonephritis. It's used first line as well as in refractory disease. There are definitely issues with the trial design in lupus, and it's widely used in the treatment of lupus nephritis, and I find it very helpful. Obinutuzumab is more potent, better side effect profile, and the question is, does CAR-T have a role in refractory disease? Thank you very much.
So a lot of this has been covered in this morning's session, so I'm going to try and just start from a slightly different angle, which is, why do we need to develop new drugs, or why do we need new drugs? What is the problem with the current treatment we have for glomerular diseases? And most of this is sort of fairly obvious, but we have a number of conditions where we have no or really no, either not a very good or really no response at all. We have, as a result of that, more side effects to benefit, which we're putting on the patients. And despite many of these treatments, as we've heard about vasculitis and lupus and membranous, there is disease relapse. So these drugs are not preventing the disease from actually coming back. And just a plug, because I know that there are some pediatric nephrologists here, many, if not all of these drugs have never been tested properly in kids, and we need to start thinking about doing trials in children. So what sort of diseases am I talking about? Well, we could think about, I've put crescentic IgA, but actually proteinuric IgA, C3GN, the immune complex MPGNs, which are the sort of most horrible disease to get when you see that on the biopsy, because there's a sort of paucity of stuff that we can do, FSGS, fibrillary N, the list actually goes on and on. What do we tend to use? We tend to use the same 3 or 4 drugs that we've used for a number of years: steroids, cyclophosphamide, CNIs, rituximab now, as Ruth has mentioned. And many of these conditions that we've mentioned already will have a tendency to relapse when you withdraw the therapy. So these are data from a rare disease registry in the UK called RADAR, which has looked at a number of rare diseases that lead to end-stage kidney disease. They are enriched in the end-stage kidney failure population. So about 25% of patients who have end-stage will have one of these rare diseases. And what these data look at is the progression of the time between diagnosis and the time that these patients reach an eGFR of 30. And what you can see is that a number of different conditions where I think we have had limited or not very good treatments show different rates of progression. Whereas in vasculitis, there's a fairly slow rate. It takes a longer time for those patients to reach a GGFR of 30. If you look at proteinuric IgA, and if you look at MPGN or C3GN, you see that there's a much more accelerated rate of progression. So we have this therapeutic window where from the time of diagnosis to the time that people reach severe kidney damage, we've got a therapeutic opportunity to try and reverse what's going on. If you look back in 2010, this is a publication about the different sorts of trials that were going on in glomerular diseases in 2010. These are dominated by diabetic nephropathy diseases. These rare diseases that I'm talking about, lupus, IgA, FSGS, very few trials going on. And why is that? Well, that's because they are rare diseases. Traditional trial design doesn't always apply to these conditions because it's hard to recruit large numbers of patients. There may be cohort studies that people keep to themselves and they don't like to put them into randomized trials. And it's fair to say that in nephrology, historically, we've not been very good at collaborating and compromising in terms of protocols. And sometimes heads need to be sort of knocked together to try and get that to happen. We don't know where all the patients are, so there may be lots of patients across the country and we don't really have access to them. So registries are very useful to find out where they are. And the main issue, I think, has been that the endpoints take too long. If you look at reaching end stage or doubling of the creatinine, that can take a number of years, and drug companies aren't really very interested in doing trials over a 5 or 10 year period for the most part. So how do we get around that? Well, I think one of the major things that has happened a number of years ago was the fact that the change in proteinuria over a 6-month period was shown to be an extremely good surrogate for long-term kidney outcomes. So these are data from a number of different trials looking at change in proteinuria over a 6-month period and correlated with change in eGFR over a 3 or a longer time period. Now, as a result of this, marketing authorization authorities, the FDA, the MHRA, have taken these studies to show that proteinuria over 6 months is an extremely good surrogate for long-term outcomes. So they're very happy to do trials which are shorter, which use proteinuria as an endpoint, which is what we've heard about a lot earlier on today. And as a result of this being accepted by the regulators, drug companies are extremely interested. So what does it look like now? Well, now in 2023, if you look at clinicaltrials.gov, you can see that these rare diseases have really proliferated in terms of the number of studies that are going on. IgA, over 100 trials, FSGS, membranous, minimal change disease, and C3GN that didn't even appear on this graph that I showed you from 2010 now has over 50 different trials looking at treatment for MCGM. So rare diseases are now coming to the fore. So fast forward to what I'm meant to be talking about, which is complement and glomerular diseases. We've known for a long time from histopathological studies that complement is deposited in a large number of conditions. And I've named a few of them here. Atypical HUS, IgA, I'll come to ANCHOR in a minute, C3GN, obviously, lupus, and a number of others. We know that there are abnormalities in the complement pathway which are either genetic or acquired. So patients have polymorphisms in some of the complement regulatory proteins or in the complement proteins themselves. And that might be a primary driver, for example, in C3 glomerulonephritis, or it might be part of an amplification loop, for example, in lupus due to the deposition of the immune complexes. In some conditions, more than one complement pathway is involved. And I think we heard earlier on today on the IgA talk that both the lectin pathway and the alternative pathway have both been implicated in IgA. And as a result of this, a number of therapeutic strategies have come to the fore: monoclonal antibodies, inhibitory RNAs, and small molecule inhibitors. And if you look at this non-exhaustive, and you're not meant to read it, in fact, you can't read it. If you look at this table, a number of different conditions have now been or are now being trialed with the use of complement inhibitors: atypical HUS, C3GN, IgA nephropathy, and we'll talk about a few of these. This is the sort of thing that in medical school you try to ignore because it's a really tedious kind of aspect of pathophysiology and immunology. The complement pathway, which is incredibly difficult to get your head around, I think, but essentially there are three parts to this. The alternative pathway, which is always on and actually contributes to the vast majority of the amplification loop of complement. So most of the complement activity that we find in the kidney is related to alternative pathway activity. The lectin pathway, which are proteins that respond in association with bacterial infections, stimulate cleavage of C4 and C2, which is in the classical pathway, and they then lead to C4 activation in the convertase. All of these pathways will then interact on the central part, which is C3 being activated, which in turn will activate C5. That will lead to the membrane attack complex, as well as producing byproducts, just C5a, which are the anaphylotoxins, which will recruit more leukocytes into the sites of activation. So classical pathway, immune complex activation, the lectin pathway, and the alternative pathway. And the alternative pathway I think of as a automatic car, which has got the accelerator always on, which you're having to keep pushing the brake on to stop the car moving forward. And these brakes are regulatory proteins that prevent the activation of C3b. Now, there are a number of drugs that have been produced that will interact, antagonize different parts of the pathway, factor B, factor D, which are both there to promote C3 activation, inhibitors of the lectin pathway, and then more terminal inhibitors of the C5 portion of the pathway, or the C5a receptor, which I spoke about earlier. So you will all know the most famous probably complement antagonist that is available that we use is C5 blockade, and that's been tested originally in paroxysmal nocturnal hemoglobinuria, but now is used for atypical HUS. This is the study really that put it in its place. A small number of patients treated for just over 6 months. Interestingly, about 9 to 10 months after they were originally diagnosed with atypical HUS, and the outstanding results, which were that 4 out of 5 patients who were dialysis dependent regained independent kidney function after being treated with eculizumab. There have been meta-analysis since then showing that over 100 patients have been treated. The vast majority who were dialysis dependent recovered independent renal function. Now, it's fair to say that these trials have never been controlled or randomized. These have been open label studies. And you can see the sort of results that we get here in GFR in the pre-treatment period. Once eculizumab is started, GFR comes up very nicely and is maintained when eculizumab is carried on. And similarly, in the second small study in the pre-treatment period, pre-treatment period where there's a slight dip in the GFR, which then comes up following treatment. So eculizumab has been shown to be extremely effective in atypical HUS. In certain countries where it can be used, it's been the standard of care. In the UK, it's commissioned and we have restricted access to it, but nonetheless, we do have access to it. There is a new version of eculizumab which has been modified, which now doesn't undergo the same lysosomal breakdown, and so therefore has a longer half-life and can be used every 2 months rather than every week or fortnight. And as far as we can tell, although they've never been tested head-to-head, it seems to be just as effective. And as you heard earlier on from Adrian, there's now a trial in IgA nephropathy as well as in lupus nephritis to see if that's useful. So what about the sort of the most obvious disease that we could treat with complement antagonists? That's C3 glomerulonephritis or MPGN. So we know that there are abnormal complement regulation in these conditions. We know that there are a number of abnormalities or antibodies to these complement regulatory proteins. And we know that there are nephritic factors that might be present that can stimulate and stabilize the C3b convertase, keeping the alternative pathway more active. So the first one that was tried was eculizumab because that made sense. What was interesting is that there was a very variable response in the outcome with eculizumab in C3GN. And now there are over 7 different complement antagonists that are being tried. So just to focus on some of these and look at the data. Factor B, so this is a drug called iptacopan, has been trialed in C3GN, both in native disease and in post-transplant recurrence of C3GN, small numbers of patients, 3 months of treatment, and then going to a continuation phase. And this was on top of standard of care, which was steroids, MMF, and RAS blockade. And you can see that there's a good reduction overall in levels of proteinuria and a stabilization and normalization of C3 levels in the serum. There is currently a phase 3 study going on called APPEAR-C3G to try and look at whether this translates in a randomized trial. Factor D blockade, both Factor B and Factor D work on the C3 pathway. This has been used in both C3GN and an immune complex MPGN. The difference between these two conditions is subtle, I would say. Both of them have the same degree of genetic abnormality associated with it, which is not very high. And in both of them, both complement and immune complexes can be deposited, although it's which one predominates. So this was a small study, again, 6 months of treatment. This was placebo-controlled and no benefit in any of the parameters looked at, so this has not gone any further. This drug is quite interesting. This is a subcutaneous direct antagonist of C3. This has been tried in both C3GN and immune complex MPGN. It was originally used in a basket trial using a number of different conditions, and C3GN showed some benefit with a rise in albumin and reduced proteinuria. So it underwent a phase 2 study. It's now completed recruitment of the phase 3 Valiant trial. And anecdotally, the one patient that we put into this study has done extremely well, although I don't know whether they had drug or placebo. The outcomes will be based on repeat kidney biopsies as well as secondary outcomes with proteinuria, and we wait to see what those results look like, but clearly looks like a promising area. Avacopan, which I spoke about in vasculitis, has also been tried in C3GN, and this is just an example of where we have to be cautious about early reports. The first report that was presented as abstract form suggested there was a benefit on index of disease chronicity when repeat biopsies were performed. The larger study, which was randomized and placebo-controlled, showed no difference. And again, this has been abandoned in the treatment of C3GN. So we heard a lot about IgA nephropathy, and I'm not going to dwell on that because Adrian and others have covered that, but essentially good evidence that the complement pathways involved in IgA nephropathy and studies of iptacopan, which has now been approved, showing benefit in terms of reduction in proteinuria if you treat for 3 or 6 months. This was a randomized placebo-controlled trial. There's evidence from the phase 3 study now showing that after 2 years of treatment, there's a 38% reduction in proteinuria. So again, a surrogate marker for what might happen over a number of years. The lectin pathway, which we heard about this morning, this has been, again, in a phase 2 study, looked optimistic, but in the phase 3 study, that has been halted and is not going to go any further because of the lack of benefit on proteinuria. The story is interesting in ANCA vasculitis because we think of this as being as porcy immune, little immunoglobulin in the kidney and not a huge amount of complement, although it's often good to go back and look at data that people have presented years ago, which have been forgotten. But Mark Hass, a pathologist from the US, showed a long time ago that if you look at all the cases of ANCA vasculitis, about 50% of the biopsies will have some degree of immune complex deposition on EM. And of those that have immune complex deposition, 3/4 have complement as well. And there have been, as a result of that, some animal studies were carried out where cobra venom factor was used to try and deplete complement completely, and showed that in this animal model, compared to no cobra venom factor, when you deplete complement, the disease is completely abrogated. And so this led to the testing of C5a because they showed that this was alternative pathway involvement. They tested C5a receptor and showed they could abrogate disease. Drug companies then took this on, developed avacopan, and subsequently we now know that complement abnormalities can be found in a subset of patients with ANCA vasculitis, and they generally portend a worse outcome. So they correlate with more cellular crescents if you've got complement abnormalities, and they associate with worse kidney outcomes. So the advocate study was performed. I've mentioned this earlier, so I won't dwell on it, showing that it can be used instead of steroids. And I've shown you these data on improvement in GFR in the whole group over the year and in the subset that had worse kidney function to begin with. So what are we going to do in the future? Well, these are single agent blockades of complement pathway. There are already talks of combining some of these monoclonals that can target common areas on both C3 and C5, so either using it as a one drug or as a combination of therapies, and then using it in other immune complex diseases such as lupus and post-infectious GM. So this is all great, but as you can tell, this isn't stopping the underlying driver of the disease. This is stopping the effector arm. So the big question to me is, when can we stop these drugs? Eculizumab has been going for a while, and so there's been a number of studies looking at, can you stop eculizumab in patients who have atypical HUS? This is a study from a number of years ago that looked at early cessation of eculizumab in patients with atypical HUS, including children. And essentially what they showed was that you could do it. There was a small number of people who had a relapse. This was about a quarter of them had a relapse, but in fact they restarted their eculizumab and didn't suffer significantly as a result. A huge cost reduction of 70%. And interestingly, it was the vast majority of people who had a relapse had a genetic variant or an autoantibody. More recently this year, the UK group led by Neil Sherrin and these are the data from the trials showing that there are some people, when you stop in the white bars, can have a prolonged period off of eculizumab without having disease relapse. Neil Sherrin's group has shown that, this is from the ASN of this year, that you can withdraw eculizumab in patients who've been on it for more than 6 months. In their cohort of 28 patients, only one person had a decline in their eGFR or developed extrarenal manifestations. 4 of them relapsed. All of them had pathogenic complement variants. And if you monitor these patients carefully, you can reintroduce eculizumab without any undue harm. So what about these other oral complement antagonists? Well, we don't have long-term data on them. We've got data on avacopan for 1 year, 2 years of iptacopan. I think the real problem is that there will be a tendency for us all, if these drugs are started, to carry them on indefinitely, and that will be at a significant cost, and we have to think about how we stop them. So a number of promising drugs, not all of which have been found to work for the conditions they've been tested in. Opportunities for some of the diseases we've got where we've had no treatment. So I think C3GN and MPGN, which has been very difficult to treat in the past. We have to figure out if there's a subset of patients who will benefit the most. Do they have worse complement abnormalities? Do they have more factor B circulating? And so on. And we really, really have to find out how on earth we use these drugs properly. Can we have drug holidays? Can we stop them? And when can we stop them? And with that, I'll say thanks very much.
Thank you for inviting me here. So I'll be talking about the role of Sibeprenlimab in IgA nephropathy. We have all discussed in the morning how IgA is important, and especially for our population, the APAC region, where it's one of the commonest causes of end-stage kidney disease in young people. And we have heard also the targets that we have to reduce the GFR fall to less than 1 ml per minute per 1.73 meters square, and also proteinuria target 0.5 gram per day or less. And we have looked at the draft of the guidelines, where on one hand, we are targeting the formation of pathogenic IgA, and on the other, we are looking at therapies which reduce the progression of kidney disease. And we have also understood the 4th hit hypothesis right from the gut, where we have drugs. We have also discussed the pathogenesis of galactose deficient IgA and the drugs. Subsequently, the complement inhibitors in the last talk you have heard as well. And we have also looked at the role of SGLT2 and sparsentan. Now, where exactly is this Sibeprenlimab? As we all know, it's an anti-APRIL inhibitor. And this trial looked at its role in the pathogenesis and its effect on the progression of IgA nephropathy. It was a phase 2 trial. And as we have seen that it decreases the generation of galactose deficient IgA. What's this APRIL? This drug blocks APRIL. What is this APRIL? APRIL is a cytokine produced mainly by myeloid cells belonging to the tumor necrosis factor ligand superfamily. The most important role is that it helps in plasma cell survival and is also involved in immunoglobulin production and class switch. And that's the key mechanism, one of the key mechanisms by which this drug acts. A mouthful, Sibeprenlimab, it blocks APRIL. So what was this trial about? It was ENVISION trial, a global multi-center phase 2 double-blind randomized multi-dose placebo-controlled study. Adults with biopsy-confirmed IgA nephropathy receiving optimized supportive treatment, they received IV Sibeprenlimab or IV placebo at monthly intervals. The aim was to evaluate the efficacy and safety of different doses of this molecule in patients with IgAN who were at a high risk of disease progression. So this trial was conducted in 98 centers across the globe in 15 countries. And you can see here, we had a lot of patients from APAC region in an answer to the question in the morning, what is the impact of these trials in our local population? So Asians were 115, whites were 36. And you can see Sri Lanka also screened 9 patients and randomized 5. So we were very much part of this trial. And I am happy to say that India was the highest recruiter globally. This was my first opportunity to participate in a trial as national leader, and I was very happy, along with Dr. Jha, that we could give a substantial contribution. So the study design was the patients were randomized into 4 groups. 3 groups were the test groups with 3 doses of Sibeprenlimab, 2 mg per kg, 4 mg per kg, 8 mg per kg, and placebo. The duration was monthly injections for 12 months. There was a follow-up period of 4 months post the last dose. It was a double-blind, randomized, placebo-controlled parallel group trial, as you can understand. The primary efficacy was evaluated at 12 months. The key inclusion criteria were, it was done in adults with biopsy-confirmed IgA nephropathy, with less than 25% crescents and less than 50% tubulointerstitial lesions. The adults should be on a stable, maximally tolerated dose of RAS for at least 3 months prior to screening. The eGFR was equal to or more than 30 mils by CKD-EPI, and screening proteinuria was equal to or more than 1 gram per day, or UPCR of greater than or equal to 0.75 gram per gram of creatinine. The key exclusion criteria were secondary forms of IgA nephropathy, nephrotic syndrome, other coexisting causes of CKD, type 1 diabetes, uncontrolled type 2 diabetes, uncontrolled hypertension, and any immunosuppression if received within 4 months prior to screening. And what were the endpoints? The primary efficacy endpoint was change from baseline proteinuria, the 24 hours UPCR at 12 months. The secondary endpoints were change from baseline 24 hours UPCR at 9 and 16 months, eGFR at 12 months, change in serum IgG, IgA, IgM at 9, 12, and 16 months, and also clinical remission, which was defined by urine protein excretion to less than 300 milligram per day. The exploratory endpoints looked at changes from baseline in circulating lymphocyte count, APRIL level, and galactose-deficient IgA levels. The safety endpoints included adverse events, clinical labs, as well as physical examination findings. The formal statistical hypothesis testing was performed only by primary endpoint. And what were the results of this phase 2 trial? So as you can see, the median age was 39 years. There was no significant difference in the 4 groups at baseline. 43% of population was females. 74.2 were Asians. Japanese formed 12.3% of the global cohort. 72% had a history of hypertension. The median time since diagnostic kidney biopsy was 565 days, and 98% were on baseline RAS blockade. So all groups were almost similar at baseline. The mean proteinuria at baseline was almost similar in all the 4 groups, around 2 gram, and the eGFR ranged between 56 to 68, which was almost similar across the 4 groups. So what were the results? The efficacy endpoints, the proteinuria, it was shown that there was a geometric mean ratio reduction in 24 hours urine PCR from baseline, significant in the Sibeprenlimab group, especially there was a dose-dependent effect with the reduction about 62% with 8 milligram per kg vis-a-vis 20% in the placebo group. Thus, you can see in this graph, there was a dose-dependent decline in proteinuria. The decline was maintained till month 16, that is 4 months after the last dose, except in the group of 2 milligram per kg, where the proteinuria started returning to baseline after stoppage of the drug. Similarly, as you can see in all the dose groups, there was a percentage change which was significantly different from the percentage change in spot UPCR from baseline. And up to 25% participants, 1/4 of them achieved remission, with a urine protein creatinine ratio less than 200 milligram per day. Looking at the efficacy as far as eGFR stabilization was concerned, so you can see that the least square mean change from baseline in eGFR at month 12. How much was it? It was significantly different in the dose groups compared to the placebo group. In placebo, the rate of fall was 7 mils, whereas you can see in 8 milligram per kg, it was around 1.5. As you can see again, the annualized eGFR slope estimate was attenuated for all the Sibeprenlimab dose groups compared with the placebo. What about hematuria? We also know that hematuria is also one of the outcome markers, and there was a significant change from baseline in the patients receiving Sibeprenlimab as compared to the placebo. What about pharmacodynamics assessment? Was there a reduction in pathogenic circulatory immune complexes? Yes, there was. And this reduction correlated very well with the decline in proteinuria. There was a significant change in APRIL levels as well. There was complete suppression of APRIL levels. The levels, however, returned to baseline after stopping the Sibeprenlimab. What about the levels of galactose-deficient IgA1? There was a 65% reduction in this molecule in both 4 and 8 milligram per kg groups. What about the levels of other immunoglobulins? IgA was reduced by 65%, IgG by 35%, and IgM by 75% in both 4 and 8 milligram per kg groups. We did this trial during the period of COVID. It was started in June 2020. And what was the response to COVID vaccine during this time? So it was realized that there was no effect in the antibody titers achieved post-vaccination with or without the drug. And this was a very happy information we could garner from this trial. What about the safety assessments? So here again, the adverse events were similar in all the groups. There were no deaths in any of the groups. In fact, there was no increased risk of infections versus placebo. So this was again a heartening finding. There were some incidences of COVID-19, but again, it was not in the dose group. It was less frequent in the dose group. You can see the other minor side effects: pyrexia, nasopharyngitis, upper respiratory infections, headache, hypertension, diarrhea, muscle spasms. And they were not significantly different between the dose groups or the placebo group. Adverse events related to infections as well were minor. None of them were life-threatening, and there was no significant difference between the placebo or the dose groups. Thus, concluding that Sibeprenlimab significantly reduces proteinuria in patients with IgA nephropathy, which was a primary outcome assessed at 12 months, and one of the secondary outcomes was stabilization of GFR. So it worked on proteinuria as well as GFR, and the drug was pretty safe with the experience from this phase 2 trial. This resulted in publication by NEJM, that was in November 2023. And in fact, the editorial in the same journal said, April, is it springtime for new IgA nephropathy therapy? So now this drug is being further tested in phase 3 trial, Visionary by Otsuka, and this trial has yet to achieve completion. Sibeprenlimab received US FDA Breakthrough Therapy designation for treatment of IgA nephropathy. This was in February 2024, and the company has also filed for accelerated approval to US FDA. So thank you, ladies and gentlemen, for a very patient hearing.